Welcome to ESOC TV. We are today here at ESOC, and at ESOC today the results of the tactics trial have been presented. This trial addressed the equity of care and the equity of reperfusion treatment throughout Australia. We got here Professor Delcourt and Professor Levi from the George Institute in Australia to ask about and cover some key aspects of the trial. We all know that equity of stroke care is a very important thing, and we all need to address this to reduce the burden of care. First of all, can you provide some details on the background of this trial?
Sure. Well, Australia is a very large geography, and we have the challenge of lots of smaller communities that are far-flung and many hundreds of kilometres sometimes from the Comprehensive Stroke Centre. So the thinking behind the trial was to think up an intervention that would support more effective access for those regional populations. About a third of Australia lives outside the capital cities, and the burden of stroke in regional Australia is actually higher than it is in the metropolitan regions. And the regional patients generally don't have access to advanced imaging. They have limited access to experts who can come and educate and train. So the idea behind tactics was to provide those smaller hospitals with the infrastructure and the education and training that they need and connect them better to their Comprehensive Stroke Centre.
Okay, so a great aim then. So what were the methods and what were the procedures put into practice in the trial to guarantee and to get to that aim?
Yeah, so we basically equipped the sites, so the small rural and regional sites, with advanced CT imaging, and then provided them with an education package which included multiple components, but one very useful component, which was a virtual reality training. And then we did regular meetings with them, like for education, but also for audit and feedback all along the trial.
Okay, so moving towards the results, because we are all curious, because you are allowing more people to get treated and you are increasing, so the aim is to increase the equity of care. So what were the results? Can you cherry pick for us some of the key findings?
So one of the key things is that this was an intervention trial, and what we did is compare the intervention and post-intervention period with the pre-intervention period, and we were looking as our primary outcome at the rates of reperfusion, and we showed that the rates of reperfusion increased by 44% in the intervention and post-intervention period, which was a pretty amazing result.
Indeed, an amazing results. So you've trained more sites, so the key question now is, what about the implementation? So what do you expect in the future?
Well, the really encouraging thing is that even when the trial finished, those sites have continued to implement and use particularly the virtual reality training modules that we provided with them. So we have a natural experiment continuing in those sites, and that uptake, I think, really does suggest the acceptability, usability, and the likelihood that guidelines will, I think, move to recommend this as a method particularly suitable to the smaller hospitals that require more of that point of care, more sophisticated education. So we're hopeful that this can be adopted. The virtual reality technology is common now, and it's quite simple really to develop such a package that will be relevant to any community or any region. Obviously our packages sort of got an Australian flavour to it, but it would be relevant, I think, to many geographies around the world.
Thank you very much, and congratulations for these great achievements, for this great trial. Thank you
very much.
Thank you.
So we're moving to the next trial, which will be covered by Professor Meinel, please.
Hello everybody. So we're moving on to the PROMOTE trial, and it is a great pleasure and honor to welcome Professor Sheila Martins from Brazil and Professor Michael Braden from Austria, who are the co-PIs of this study, which tackled in primary prevention a polypill strategy as well as a risk app on your smartphone. So first of all, I want to express the compassion of the stroke community with what was happening in your country, and probably not an easy day with both a laughing and a sad eye. So can you maybe briefly elaborate on the motivation and aims of the study?
I think Michael is the perfect person to talk about this because it was his idea and the concept was created by Michael when he was the World Stroke Organization president.
Sheila is kind as always. No, the polypill idea goes back several decades to the 80s, and the idea is as simple as it is effective, that a conglomerate of several medications are put into one pill, and that's a polypill. And people take the polypill and not 3 different ones, 2 antihypertensives, 1 statin, and so on. So one polypill makes things easier. And in combination with the riskometer, Sheila could show that it is especially effective because the problem in primary prevention always was that people say, well, I'm a healthy person, why should I take a pill? But then with the riskometer, she could show to these patients that they do have a risk of stroke. And with this educational part, they were motivated to take part. Yeah. So I think it's an ideal combination, which obviously has worked out.
Excellent. For those who don't know the stroke riskometer, I highly encourage to download the app. It is very user intuitive. It provides nice visualization of your risk, and it motivates you to a healthier lifestyle. I tried it myself on the way here to Basel, so excellent. Can you elaborate on the population that you tackled? So I understand you included adults from 50 to 75 years, and I was a bit surprised about that you could include somebody with a blood pressure of 121. So after stroke, we're aiming for 130 or below, but then in primary prevention, you can include with 121. So what's the rationale behind this?
Yeah, this is very interesting because we already know that you need to treat patients with more than 140, and if they had a stroke or myocardial infarction after 130, but we know that the risk increase from 115, and is a continuous increasing of the risk. So the concept is treating these patients, we can decrease the risk of stroke, myocardial infarction, and other disease, and cognitive decline because they share the same risk factors. So this was the idea. The pilot was designed to prove that you can use medication in this population to see if the polypill was safe, if the patient can tolerate, if it's feasible to implement in primary care, and after this, as we show that really the treatment works, is safe, we can really see the main outcomes, that is stroke and cognitive decline, as primary endpoint in the major trial, and as secondary outcomes, myocardial infarction, cardiovascular death too.
You mentioned the efficacy, so you had a blood pressure reduction of 8.2 millimeter mercury. What is your expectation towards like MACE reduction in the larger phase, and what are the other endpoints that the study had?
Yeah, we know if you decrease 2.5 millimeters, we can decrease 10% of the risk of a stroke, so it's huge. And we decreasing 80 millimeters, comparing one group to another, we can the idea of Michael is cut the stroke in half, treating these patients, because really we believe that you can decrease in half the risk of these patients starting the lower blood pressure.
Maybe a question to the methodology. So I think, as I understand, there's a combination of 2 randomizations. So a cluster randomization as well as an individual randomization. So why did you choose this methodology and not randomize individuals as well to the riskometer?
This is a very good question. We discussed a lot this. We are worried with the contamination using riskometer in the same community, in the same primary care unit. And one talk to other, and everybody start to use. So for this, initially we would randomize as cluster everybody for Polypill also, but of course we have more power if you randomize individual patients, including the placebo. So we had this idea to use cluster for hiscometer and individual randomization for the Polypill, and this sample size calculation was to evaluate the Polypill, the safety to use and to expand. But it was really a challenge to do this because some primary care units have a smaller number, ones are ready to start and the others no. So the sample is not the same. So for the expansion of the trial, we need to discuss, Michael, with the executive committee, but probably we will randomize in 4 groups individual patients.
Okay. So that might be a lesson learned, or were there other pitfalls of this pilot phase?
Exactly.
Were there other pitfalls in terms of implementation or rollout?
This population is not in the primary care unit, so we went there with the students to initial evaluation to train the nurse assistant that received the patient in the primary care unit. We stayed several days, weeks during the pandemic, but the patient were not there. The patient there is the hypertensive, diabetic, with prior myocardial infarction. This is not our population. So what we can do? So we start to call them through the media, social media, TV, radio, and also in the campaigns, we call them to the primary care unit to prevent stroke and myocardial infarction and dementia, and they start to come. So it was so incredible because the first year we include 150 patients. And after we learn, in 5 months we include the rest, 250 in 5 months. So really we learn a lot.
Wow, that is impressive and also exemplary, I think, for reach out to patients to get involved with research also if you are not in a setting where research is practiced on a daily basis. Impressive. Can you, I know it is a phase 2 study and it was not designed for that, but do you think the components, so what is more efficient? Is it the Polypill, is it the riskometer? I thought in the curves it's maybe more the Polypill, or what are you expecting in the phase 3?
The Polypill is more effective to reduce the blood pressure. To reduce the cholesterol, only Polypill had effect. To reduce the blood pressure is strong, so really can decrease a lot with the Polypill. But when we add the riskometer, we decrease more. So the best patients, the best result was Polypill plus riskometer against usual care plus placebo. So really, I think riskometer add. And Michael told a very important thing about the improvement of all patients.
Yeah, well, the issue is that in primary prevention, the dropout rate usually is around 30%. And it was about 5, was it? 5
for adverse events, but in total was 15%.
Yeah, so much less than to be expected. And I think that's due to the educational effect of the riskometer. So it's a multiplicity of both. So you have to educate the people so they understand that they are at risk, and then they are motivated to participate. And so Sheila is very good at that, getting patients coming along and joining the trial. So I think this really worked out fine.
And maybe it's also a lesson for trialists to implement such e-health opportunities if it then enhances your trial quality with the data quality that you mentioned.
Absolutely, yes.
Can you maybe, I know we neurologists don't like it, but cardiology has done some Polypill trials like
the Polypill trials from cardiologists are secondary prevention. And for secondary prevention, the Polypill has been accepted also by the WHO. It is now accepted in the list of essential medicines. So there is no discussion about that. But the issue is primary prevention, because there it can be even more effective. So we think that actually the number of strokes can be reduced by 50% around the world, around the globe. So that's the power of primary prevention, and that's the way to go, because if you need a recipe for one hypertensive, for another hypertensive, and for a statin, and the doctors are not always available, and the nurses are not allowed to give prescriptions, and so you have a Polypill, you know. This makes life much easier for many people, especially in countries like Brazil, but in principle, Europe is not really different.
Can you comment, because I, as a physician in Switzerland, don't have the opportunity to prescribe a Polypill yet. Can you comment on the availability of Polypills?
Oh, you can prescribe. There is one licensed in Switzerland, but it's not covered by the insurance, so people have to buy it.
Okay.
Is the very low cost. This Polypill is $4 per month per patient. That is a low-cost Polypill. And the discussion with the minister that we have a company to produce a public one. In 5 years, the medication will be property for the Ministry of Health to give for free for the population.
Yeah, that's the plan.
That's excellent.
Yeah. I'm sure in Switzerland it's not so cheap.
We'll see. Okay, are there any things that you want to add about the trial? Anything that didn't come up that you think it is important to the viewers?
Well, I'm so proud because I think really this can have a huge impact in our population. And after the patient is engaged, they believe that they can improve. It's not only this, we have a team to motivate the patient and to help them to modify lifestyle. This is very important for this. His committee is important to show that it's feasible to do this.
Well, thank you so much, Professor Martins, Professor Brainin, for joining. For the viewers, I wish you a nice evening. Enjoy the after ESOC parties. Make sure to come tomorrow to the interesting program. And for those watching online, and enjoy some more ESOC content in the ESOC channel. Thank you. Bye.